Welcome to Deep Dive Ortho, where we explore the critical issues facing surgeons today. We're delving into something fundamental to our practice. Surgical complications. They're inevitable, we all know that. But how we deal with them, clinically and personally, shapes so much of our professional lives and the care our patients receive. So today, we're doing a deep dive into three really vital areas. We'll start with the psychological impact on us, the surgeons, the whole second victim phenomenon. Then we'll get into the weeds of diagnosing fracture-related infections, FRI, which, as you know, can be incredibly tricky. And finally, we'll touch on that important line between unavoidable complications and medical negligence. And guiding us through this is a leading expert whose insights are invaluable. A very warm welcome.
Thank you. It's good to be here. These are certainly crucial topics, and I'm keen to discuss them.
Great. Okay, let's start unpacking this. We all have a working idea of a surgical complication, but it's interesting that a standard definition didn't really exist until the early 90s, with Clavian et al., suggesting any deviation from the normal postoperative course. What does that definition really mean for the surgeon standing there when things don't go as planned?
Well, that's the fascinating part, isn't it? The idea of a normal postoperative course is inherently subjective. It's not fixed. It shifts based on the surgeon's own skill set, the patient's health, their comorbidities, and crucially, the resources available, the kit, the support staff, everything. So what's normal in one setting might not be in another. When these deviations happen, that's when we see the second victim effect kick in. It's a term that recognizes the significant, often hidden burden on the clinician involved in that adverse event. Wu highlighted this back in 2000, really bringing attention to the impact on us.
And we're not talking about rare events here, are we? With something like 200 million operations globally every year, the potential is huge. Studies like the Harvard Medical Practice Study found adverse events in nearly 4% of hospitalizations. That's a substantial number.
It is. It underscores that these aren't exceptions. They are part of the landscape of surgery. And while our immediate focus is rightly on the patient, the first victim, and their family, the effects ripple outwards. For the patient, the harm isn't just physical. Of course, complications can range from, say, a minor wound issue, a Clavian grade I, maybe needing simple bedside drainage, right up to catastrophic, life-threatening events requiring intensive care, multiple surgeries, or even leading to mortality, the higher grades, IV and V. But beyond the physical, there's the financial strain, the time off work, and the deep psychological impact.
Yes, that psychosocial toll is increasingly recognized. Surgery itself can be traumatic, and a complication just layers more trauma on top. It affects not just the patient, but their whole support network, causing lasting emotional distress.
Precisely. And acknowledging that is vital for truly holistic care. There are models out there, like those used for childhood traumatic stress, which focus on identifying and mitigating that psychological harm. We could certainly adapt and adopt similar approaches more widely in surgery, looking beyond just the physical repair.
Which brings us squarely to the impact on us, the surgeons. That old saying, if you haven't had a complication, you haven't operated long enough. It rings true, doesn't it? It's baked into the career. So what does the research tell us about the typical psychological fallout for the surgeon?
It's unavoidable, unfortunately. The suffering is real and perhaps underacknowledged. A major review in 2020 pulled together the data, and the figures are quite stark. Among healthcare providers after an adverse event, things like troubling memories were reported by 81%.
81%, that's huge.
It is. Then anxiety and concern, 76%. Anger at oneself, 75%. Regret, remorse, 72%. General distress, 70%. Fear of making future errors, that hangs over you, 56%. Embarrassment, 52%. Guilt, 51%. Even sleep problems, 35%.
These aren't just minor worries then. This sounds much more significant.
Absolutely. This isn't simply stress. These symptoms can mirror acute stress response. Even PTSD. We used to associate PTSD mainly with massive traumas, but we now understand it can follow common events, including medical procedures that go wrong. And it's not just psychological. It affects cognition, decision-making, concentration, potentially leading to more errors. It impacts physical health, too. It's a heavy burden.
So what makes one surgeon react more intensely than another? Are there specific factors that amplify this second victim response?
Yes. Several factors seem to play a role. Firstly, the relationship with the patient. If you've built a strong rapport, invested time, understood their hopes, an adverse event hits harder. It feels more personal, much like when something happens to a loved one versus a stranger. Secondly, for trainees, longer rotations often mean deeper involvement, a greater sense of ownership. While positive in many ways, it can intensify their emotional reaction when things go wrong. They feel immense responsibility. sometimes disproportionately so, and often lack the established coping mechanisms or support networks of senior colleagues. And personality is definitely a factor. Surgeons who tend to internalize things more, perhaps perfectionists, or those whose identity is very strongly tied to their surgical outcomes, they may be more vulnerable to the negative impact.
It sounds like certain groups might carry a heavier burden. You mentioned trainees. Are there others particularly at risk?
Research does suggest that yes, trainees, certainly, early career surgeons finding their feet. Female surgeons often report higher stress levels. Minorities too. Anyone really in a position of lower hierarchical power within the system can feel more exposed and less supported. There's a study in Uganda, for instance, that quantified this. Being a female doctor significantly increased the odds of a negative impact on practice after an event, an odds ratio over 2.6. Worrying about reputation, odds ratio over 3. Guilt, even higher, over 4.4. It clearly shows how these factors intersect and amplify the stress for certain individuals.
Given how widespread and significant this is, what needs to change? What interventions, what cultural shifts are needed to better support surgeons as second victims?
Well, a fundamental starting point is transparency. Open, honest communication with the patient and family is paramount. Trying to hide or downplay errors almost always backfires, worsening outcomes and deepening the psychological distress for everyone. Historically, medical training focused intensely on technical skills. Communication, while taught, perhaps wasn't always given the depth needed for these difficult conversations. Delivering bad news poorly just adds another layer of trauma. So the current push to really standardize and improve training in how we communicate adverse events is incredibly important. It helps manage expectations and build trust, even when things go wrong.
And beyond individual communication skills, what about institutional support?
Absolutely critical. Formal support programs are needed, peer support groups, easy access to confidential counseling. But just as important is fostering an informal culture of support, where colleagues recognize the signs of distress in each other and feel able to offer support or just listen. It's about normalizing the second victim experience, making it okay to talk about it, okay to seek help without fear of judgment or perceived weakness. Mentorship is key here too, especially for those vulnerable groups we mentioned, junior surgeons, female surgeons. Having an experienced guide who's been there can be invaluable in navigating these emotional challenges and preventing burnout.
It sounds like it connects to a bigger societal view of medicine, too, moving beyond just fixing the physical problem.
Exactly. Society often focuses very heavily on the physical outcome, sometimes the cosmetic outcome. This can create an exaggerated negative response when complications occur, making them the sole focus. If we could shift towards valuing emotional and, yes, spiritual well-being alongside the physical for both patient and surgeon, it might lessen some of that intense pressure when things don't go perfectly. It's about a more holistic definition of successful care.
That's a really important perspective. Let's pivot now, bringing it back to the clinical sharp end, a common and often complex challenge you face in orthopedics: diagnosing fracture-related infections, FRI. Getting that diagnosis right and early is crucial, isn't it?
It absolutely is. Accurate early diagnosis of FRI is critical, but it remains a significant practical hurdle. We see quite a bit of variation in how clinicians approach the workup, partly because clear, up-to-date guidelines haven't always kept pace with technology, and the field is constantly evolving. The mantra really has to be getting it right first time. A missed or delayed diagnosis isn't just inconvenient. It can lead to chronic infection, multiple surgeries, prolonged antibiotics, major functional loss, and sometimes even amputation. So nailing that early diagnosis prevents immense suffering and cost down the line.
We often start with blood tests, CRP, white cell count, leukocyte count, or LC, ESR. How reliable are they in the context of trauma or recent surgery?
They're part of the picture, but they have definite limitations, especially in trauma patients. The problem is, non-infectious things can push them up the trauma itself, the systemic inflammatory response to surgery, other inflammatory conditions. A big fracture or major operation causes inflammation anyway. A recent meta-analysis really underscored this, showing quite limited diagnostic value for CRP, LC, and ESR individually in late FRI. Combined scores might be slightly better, but often still not enough for a definitive call.
Do we have figures on their sensitivity or specificity?
Yes. The review found mean sensitivity for CRP was around 0.83, which isn't bad, but for LC it was only 0.39 and ESR 0.45. Specificity varied. The point is, they lack the power to reliably rule infection in or out on their own. And crucially, you have to consider the timing. You generally shouldn't rely on CRP within 14 days of surgery, LC within 7 days, or ESR within 6 weeks because of that expected post-op inflammation. Testing too early gives you false positives.
So if bloods are limited, imaging becomes even more important. How has imaging evolved to help us pinpoint FRI?
Imaging is key, and the evolution has been remarkable. We started with nuclear medicine using gamma cameras for 2D planar images. The quality wasn't great, spatial resolution was poor, maybe 8 millimeters, making it hard to localize infection accurately with overlapping structures. Then came SPECS, single photon emission computed tomography. That was a big step up. Collecting images from multiple angles gave a 3D view, much better contrast and sensitivity for localization. And then PEK, positron emission tomography, arrived in the 90s. This visualizes physiological processes. It uses positron-emitting radionuclides. The physics allows for inherently better spatial resolution, especially now with modern time-of-flight TOF software. It's a much sharper image, metabolically speaking.
And the real power now seems to be in combining the hybrid systems.
Exactly. Hybrid systems like SPECT-TT or PET-CT are becoming indispensable. They overlay the functional information from SPECT or PET onto the detailed anatomical map from CT. You see where the metabolic activity, potential infection, is located within the bone or soft tissue. This allows for earlier, more accurate diagnosis. Studies show that combining white blood cell scans or antigranulocyte antibody scans with SPECT-CT or a FDG-EPD with CT offers the best diagnostic accuracy for peripheral post-traumatic osteomyelitis. These hybrid techniques are increasingly seen as the imaging gold standard for FRI.
What about older techniques like bone scans? Are they still relevant?
Bone scans have a major limitation in this context. They stay positive for a long time after surgery or fracture due to normal bone healing and remodeling, potentially up to 2 years after a hip replacement, maybe even 5 after a knee, and probably 1 to 2 years after OF or fur trauma. So a positive bone scan shows bone activity, but it doesn't reliably tell you if it's infection or just healing. They lack specificity in the postoperative or post-trauma period.
And MRI, where does that fit in?
MRI is still incredibly valuable. Its strength is in soft tissue detail and bone marrow assessment. It's particularly good at helping distinguish reactive osteitis bone inflammation without infection from true osteomyelitis based on signal characteristics on different sequences, especially T1, T2 fat suppressed, and postgadolinium T1. MRI can also clearly show associated collections like abscesses within the bone, under the periosteum, or in the soft tissues, and track sinus tracts. That anatomical detail is crucial. But, like all imaging, it's not perfect. Patient factors matter. For white cell scans, for example, obesity can cause false positives. An odds ratio over 11 was found in one study. And very low-grade infections might not generate enough white cell response to show up clearly on a WBC scan. So context is everything.
Beyond imaging, getting the microbiology right is absolutely fundamental, isn't it? What's best practice for sampling?
This is absolutely core to confirming a FRI. The AOE-BJIS consensus group strongly recommends a strict protocol. You need at least 5 separate tissue samples taken surgically from the suspect site.
5? Why so many?
To maximize the chance of hitting an infected area, as infection can be patchy, and to minimize sampling error. And crucially, use clean instruments for each sample to avoid cross-contamination. That's vital. Also, antibiotics should ideally be stopped for at least 2 weeks before sampling, the antibiotic holiday, to allow bacteria to grow, and hold any surgical prophylaxis until after the last sample is taken.
Right, to avoid suppressing growth.
Exactly. The goal is true positive cultures. Identifying virulent organisms like Staph aureus, especially from sodication fluid off the implant, is a very strong indicator. And techniques like MALDI-TOF mass spectrometry now give us rapid, precise identification of the specific mug, helping tailor antibiotic therapy much faster and more accurately than before. These meticulous steps are non-negotiable for reliable diagnosis.
That's very clear. Just briefly, what does the typical patient profile look like for FRI? Does understanding the demographics help?
It does help with awareness and risk stratification. Typically, FRI patients are more likely to be male, around 68–70%, median age often in mid-50s, but with a wide range. Lower extremity fractures dominate, over 80%, especially tibia and femur. Open fractures are common, nearly half, which makes sense given the contamination risk. And plates are the most frequently involved hardware, maybe just over half the cases. Knowing this helps maintain a higher index of suspicion in these patient groups.
Okay, that's a fantastic overview of the diagnostic challenge. Now, let's move to our final segment, circling back to where we started with complications, but looking through a legal lens. There's that critical line between an accepted complication and negligence. How is the standard of care defined legally for surgeons?
That's a crucial distinction. The standard of care is essentially what a reasonably competent surgeon with similar training and resources would have done in the same situation. Given our extensive training, surgeons are rightly held to a high standard. But, and this is important, not every mistake or bad outcome is negligence. Medicine isn't perfect, surgery carries inherent risks. Some degree of human error is acknowledged, and some tissue damage during a really complex operation might be unavoidable, even with optimal care. The legal question is whether the surgeon's actions, or lack of action, fell below that reasonable standard.
So if a complication itself isn't automatically negligence, what are some clear-cut examples where the line is crossed?
There are several well-defined categories. One is significant organ or nerve damage beyond what might be reasonably expected. A slip of the knife causing permanent nerve palsy, or failing to notice and repair a bowel injury during an abdominal case, leading to sepsis that's likely negligence. Another is post-surgical infections directly caused by a breach in sterile technique, using improperly sterilized instruments, for example. If that link can be proven, it's negligence. Then there's negligent post-operative care, discharging a patient too soon when they're clearly unstable, or failing to recognize and act on signs of a developing complication like compartment syndrome or bleeding after the operation is completed. The care doesn't stop when the patient leaves the theater. We also have the so-called never events. These are things that simply should never happen. Wrong site surgery, operating on the wrong limb or level. Wrong patient surgery. These are indefensible failures of basic safety checks. And finally, retained surgical items, leaving a swab, needle, or instrument inside the patient because of an incorrect count or lack of care during closure. That's a clear breach of the standard.
You mentioned something important there, the response after a complication occurs.
Yes, absolutely. Even if the initial event, say damaging an adjacent structure, was arguably unavoidable due to difficult anatomy or pathology, the failure to recognize that damage or the failure to take appropriate steps to repair it or manage its consequences can itself constitute negligence. The duty of care includes vigilance and appropriate response throughout the entire perioperative period. Often the legal claim centers not on the initial injury, but on the inadequate management afterwards.
So if a patient believes negligence occurred, how is that actually proven legally? What's involved?
It requires strong evidence. Firstly, expert medical witnesses are crucial. Surgeons in the same field review the case and testify whether the standard of care was met, and if not, how the defendant surgeon deviated from it. Secondly, the medical records are scrutinized in detail. They need to be accurate and complete. Poor record keeping can be very detrimental to a defense. Thirdly, a subsequent examination by another doctor can provide objective evidence of the harm suffered and its likely cause. And sometimes eyewitness testimony from theater staff or nurses can be relevant, describing what actually happened during the procedure or post-operatively. The process usually involves discovery, where lawyers gather evidence, request documents, and question people under oath depositions. It's often lengthy. But it's worth noting that most claims, even if a lawsuit is filed, are settled before they reach a courtroom, often once the discovery process clarifies the strength of the evidence.
We've certainly covered a lot of ground today, from the deeply personal impact of complications on surgeons, through the complexities of FRI diagnosis, right up to the legal standards that govern our practice. What really stands out is the intricate blend of technical skill, emotional resilience, and unwavering commitment to patient safety that defines surgery. Recognizing the second victim helps us build a more supportive culture. Mastering diagnostics, like for FRI, is fundamental to good outcomes, and understanding the legal standard reinforces the professionalism we all aspire to. If you found this deep dive valuable, please do consider rating and sharing it with your colleagues. It really helps others find these discussions. And perhaps a final thought to leave you with. As we push the boundaries of surgical technique and technology, maybe the next great frontier isn't just perfecting the operation, but mastering our human response to the inevitable complexities and challenges. What further cultural shifts do we need within our teams, our institutions, and ourselves to ensure every surgeon feels supported through difficult times and every patient truly receives holistic care, physical, psychological, and emotional?